Hello everyone, my name is Sarah Alnaif. I'm a third-year medical student here at EVMS. Today I'll be presenting a case series of 20 patients with comorbid hidradenitis suppurativa and human immunodeficiency virus, a retrospective single-institution chart review. Unlike HIV, hidradenitis suppurativa, also known as HS, is not as well known. HS is an inflammatory periphylic disorder most prevalent in the intertriginous areas of the body. It can be quite a debilitating disease due to the pain and stigma that may be associated with the lesions. I've included a sample photo of HS as well as a diagram of the common areas of involvement. HS has been associated with many comorbidities, such as metabolic syndromes, anxiety, depression, Crohn's disease, acne, and PCOS, but there is no established relationship between HS and HIV. HS severity is often characterized through the use of the Hurley staging system, ranging from 1 to 3. There have been 2 studies conducted previously that analyzed patients with comorbid HS and HIV. The first found a higher incidence of HS diagnosis in patients with HIV than those without. The second found that patients with comorbid HIV and HS were diagnosed with HS at a later age than patients without HIV. In addition, that study also reported that the majority of patients were diagnosed with HIV prior to HS. In both HS and HIV, there are elements of common pathogenesis. A possible relationship between HS and HIV could also be attributed to HIV-associated endocrinopathies, which have been shown to further exacerbate patients' HS. Obesity secondary to hypothyroidism and lipodystrophy was noted in HIV patients. Increased rates of insulin-resistant pancreatic dysfunction and diabetes mellitus, as well as elevated cortisol levels and decreased DHEA levels were noted in HIV patients, which all can contribute to worse outcomes from HS and increased risk of infection. From the literature review, it became clear that there could be a relationship between these 2 diseases, but there wasn't any definitive answers. So that is what we aim to begin answering through this study. A retrospective chart review with strict inclusion and exclusion criteria was performed over a 10-year period from January 2010 to November 2021 that resulted in 20 patients. Each encounter for infectious disease and dermatology here at EVMS was recorded to monitor the progression and treatment of HS and HIV. Disease severity and treatment regimens were recorded for each encounter in both specialties to examine whether there is a unique presentation of HS in the setting of HIV. If a patient was managed for either condition at an outside clinic, they were excluded from the study. I've included some of the information we collected for each encounter on the slide. From a preliminary review of our results, we were able to identify some patterns. Consistent with previous research, a majority of our patients were female, with the majority identifying as Black or African American. The average age of first visit was 35.3 years old. The majority of patients were diagnosed with HIV first, with an average time between diagnoses of 10.20 years. The average BMI noted across all encounters was 31.92. The most noted comorbid conditions were depression, hypertension, obesity, hyperlipidemia, acne, generalized anxiety disorder, anemia, diabetes mellitus, followed by polycystic ovarian syndrome. However, from our preliminary results, it is difficult to pull out specific patterns in regards to the treatment regimens. Descovy and Icentris were noted to be the medications used most while patients were having an HS flare. Biktarvy was used in many encounters with early stage 2. More statistical analyses are being conducted to analyze this data further. In order to create an internal metric for acute severity versus chronic severity of HS, we assigned a flared versus non-flared state and noted Hurley stage based on notation within chart notes for each dermatologic encounter, respectively. In the dermatology encounters, patients' HS was described primarily as Hurley stage 2, followed by stage 1 and stage 3. In 69% of dermatology encounters, patients' HS was noted as flared, indicating a more acute state of disease. The most commonly involved sites of HS involvement were the upper extremities, lower extremities, trunk, neck, and head. The average viral load CD4 count and percent CD4 counts across the study periods were 20,421.6, 801.91, and 35.31% respectively. There was a wide range in the use of treatments for both diseases. HS severity had no significant relationship with CD4 count, but did with the percent CD4 lymphocytes. There was no significant relationship observed when comparing HS Hurley stage to CD4 count and percent CD4 count. Within this cohort of 20 patients, we cannot yet confidently say there is a difference in the presentation of HS when in the setting of HIV. So where do we go from here? There have been rare instances of a descriptive analysis examining patients treated for both HS and HIV. The present study aimed to first categorize this cohort of patients to then allow for more comprehensive statistics to examine whether there may be any associations between these 2 debilitating diseases. Future directions include continuing analysis of the data, as well as a larger scale study possibly involving multiple health systems to have a larger patient population for more robust analysis. Thank you for your time and attention.